Welcome, my friends, to the show that never ends, another Puscast. This one covering the last 2 weeks of January 2015. Before we get to the medical literature, I would like to take the opportunity to pimp my own products. The Pus Whisperer is now available on Amazon. It's a Kindle book. It's a hard copy book. It's the first year of my infectious disease blog, Rubor, Dolor, Kalor, Tumor, before I wandered on over to Medscape. So these essays are now unavailable anywhere else. It's the perfect gift for the pus lover in your life. Now that we're done with the advertisement, as usual, this is brought to you by Pusware LLC. You can find links to my growing multimedia empire, as well as the references to this Puscast over at edgydoc.com. Otherwise, we will now move on to the literature. It's looking like a bad flu season. I'm glad it looks like it peaked a couple weeks ago. Most of the literature about influenza will then come out 6 months from now as we pick up the pieces after this year. There is one curious little study out about the flu vaccine this year out of JAMA. They looked at a group of patients, a mere 36, who had trouble smelling. That's not an issue with my son. And compared those to patients who did not have problems with smelling. Those who had olfactory problems did so after a respiratory infection and found that there was an association between having the influenza vaccine and having lost your smell. If you had the vaccine, you were less likely to have smell problems than if you did not have the vaccine. Small numbers, but respiratory viruses, including influenza, do have the potential to affect smell by damaging the respiratory lining. So it is plausible that influenza vaccine could protect you from losing your sense of smell. What we need is for the influenza vaccine to prevent people from producing smells. That would be a benefit and a boon to mankind. I do spend a significant time in the anti-vaccine world, and it's always argued that vaccines don't really work. They do. The study looked at the efficacy of both the varicella vaccine and the zoster's vaccine in terms of hospitalizations in Connecticut, which would be an indirect effect of the vaccine. And they showed that varicella hospitalizations, primary chickenpox, fell 83% after the introduction of the vaccine. Zoster hospitalizations were increasing 5% per year from 2001 to 2006, which I think is interesting, and one wonders if the varicella vaccine, by preventing adults from being re-exposed to chickenpox, is leading to decreased immunity over time and more zoster. That has been argued back and forth in the literature, but I find it a relatively compelling argument. But after increasing 5% per year from 2001 to 2006, it then started to decline each year by 4%. So the varicella vaccine has been beneficial in preventing hospitalizations of chickenpox, and it's been beneficial in preventing zoster admissions in the adult population. So another boon from vaccines. Compazine, a.k.a., let's see if I can pronounce the generic correctly, prochlorperazine. Compazine, like Lasix, I got in the habit of using as the brand name, and I never reprogrammed my brain to call them furosemide and prochlorperazine. I mention this drug only because there's a curious article in the Journal of Infectious Diseases that showed that, I'm going to call it Compazine because I can remember the name that way, is effective at least in vitro and in animal models for both treating and preventing dengue. We also have a vaccine coming down the pike, but dengue is coming north into the United States, and it may be one of those diseases we will be seeing more of in the coming future. It is interesting that this drug may have efficacy against the virus by both binding and entry of the virus into the cell. Plus, the patient doesn't get nausea, vomiting, and headache, which is what I always used it for. Not me personally, but as a prescribing physician, as a house staff, years and years ago. So put compazine in the back of your mind for the dengue outbreak that may be coming our way. HIV neurocognitive disorders, or as they call it, HAND, is a problem. This study looked at what happens in patients in the era of antiretroviral therapy. And surprisingly, a significant percentage of patients declined in their neurostatus despite highly active antiretroviral therapy. When followed longitudinally, 22% declined and 60% remained stable, and only 16% actually improved their neurologic function by testing in this study. I was surprised at that. I would have thought that antiretroviral therapy would have shown more improvement. There were a lot of things, however, associated with neurologic decline in these patients, including lab testing and other comorbid conditions. So the neurologic decline that is seen in AIDS patients is more than just due to the HIV disease, but is, as is often the case in medicine, multifactorial. I always like origin stories, although this is not the equivalent of being bitten by a radioactive spider. This is a bite story. It's long been suspected that both HIV and HTLV have come from monkeys to humans by one form or another. This study looked at Gabonese individuals who had received bites while hunting, and of these 78 people, 7 became infected with HTLV1. 5 of them had been bitten by gorillas, which I think is curious, and others had been bitten by other monkey strains to get a different HTLV. So it looks like a bite in Africa, if you're out hunting the monkeys, is a gorilla is an ape, isn't it? Is a source for HTLV and could have been the source for the virus that's now circulating in human beings. If I was hunting gorillas, though, I think I'd wait till it was dead before I got close enough to mess with it so I wouldn't get bit. And I wonder what gorilla tastes like. Probably not chicken. But hungry people will eat. That is how one of the recent Ebola outbreaks started. A woman came across a dead monkey. I would go, ooh, she thought dinner. Took it home, butchered it, and got Ebola. As the Borg say, resistance is inevitable. This study out of Zhejiang, Zhejiang, China, looked at the resistance of mycoplasma in an adult population, and it was staggering. 100% of the strains were resistant to erythromycin, clarithromycin, and azithromycin. High resistance rates have been reported in Japan and modest at best in the United States, but 100% resistance is pretty awful. Speaking of mycoplasma, there is a new mycoplasma isolated in patients predominantly with primary antibody deficiencies. These patients get a relapsing pneumonia and can often spread it. And it's a new, hitherto unreported mycoplasma. And so they were nice enough not to give a pronunciation guide. So I'm going to guess and say that it's mycoplasma amphoriform, AMPHORIFORME, or maybe it's amphoriforme. I don't think so. Usually you don't pronounce the E at the end of a name, except my wife's last name. Be that as it may, it's probably a board question when you have a relapsing pneumonia in someone with primary antibody deficiency. That would be probably ID boards. But think of mycoplasma, however you pronounce it, amphoriform. Amphoriform. At least it's not PJP, huh? It looks like there is a plague in Madagascar right now. There's been lots of flooding in the small country. This has led to both rats and humans leaving their homes, and they've had 213 cases of plague with 57 deaths, about 25%. Probably as bad as Ebola would be in the West. I haven't seen Donald Trump pontificate about it, so it might not be important yet. But it's yet another case of changes due to weather, which then result in the spread of disease as humans and disease vectors mix. And as long as we're on the topic of rats, somebody took a bunch of rats in New York City. It's only, by the way, the 4th rattiest city in the United States, with Chicago leading, followed by Los Angeles and Washington, D.C. They estimate that there are 2 million rats in the New York area with 8 million people. So there are actually more people than rats in New York City, contrary to the popular belief. But they looked for the presence of pathogens in all these rats and found a nice hodgepodge of organisms. They found E. coli, Bartonella species, including Elizabethae rochalemia and Tribocorum, as well as Streptobacillus, which would be no surprise, but they found the occasional rat that also had leptospirosis, Shigella, intrainvasive E. coli, Campylobacter, and Salmonella. And one rat each had C. diff and Yersinia intercolytica. They also found some Cryptosporidium in a couple of rats. What they didn't find? Listeria, Rickettsia, Toxo, Vibrio, and Yersinia pestis. Thank goodness, no plague in New York City. But it would appear that the rats are at least a nice vector for other infections in New York City. By the way, speaking of New York City, I will be there April 10th. The Northeast Conference for Science and Skepticism is having a one-day science-based medicine addition to their normal program. So Friday, April 10th, myself, Steve Novella, Harriet Hall, Jan Bellamy, and David Gorski will be giving a full day of science-based medicine lectures, panels, and even a Jeopardy game. Go to necss.org and sign up. I don't know if it will be a rat-free conference. Yeah, I know, it's a recurrent theme, blah, blah, blah. Infections lead to vascular events. But that is important, and there's now 2 more studies to show that having an infection increases your risk of vascular events. This study looked at the effects of septicemia on a population in Taiwan, and they had an increased risk of stroke, especially in younger age groups. Unfortunately, they were hemorrhagic strokes, so that would make prophylaxis with aspirin a problematic intervention. The other study looked at the association between pneumonia and the subsequent risk of cardiovascular disease. And if you were admitted with pneumonia, it increased your long-term risk for cardiovascular disease, i.e., MI, stroke, or fatal coronary disease. The risk was highest in the first year after your pneumonia. There was one randomized controlled study that showed that aspirin prevented vascular events after pneumonia. This is the future. We're just not there yet. You may be aware that there was a recent randomized clinical trial that showed that Augmentin was better than placebo in relieving low back pain, specifically people who had what are called modic type 1 changes, where you have disc herniation with edema on both end plates. I tend to call that a discitis pattern for an MRI. The study was interesting, though, in that people did get better on antibiotics faster than placebo. Given that it was Augmentin, they probably knew they were in the treatment group by all the diarrhea they got. That being said, this was a meta-analysis that has looked at all the studies relevant to the fact that is there microbiologic infection in some discs. They found 9 studies, and all the studies identified organism in the disc space, the most predominant one being Propionibacterium acnes, which was found in 7 of the 9 studies, and overall found bacteria in 34% of the discs evaluated. This is culture, which would probably markedly underestimate the presence of anaerobes, for example, such as Propionibacterium acnes. They conclude that the evidence currently between the relationship between infections in a disc space and symptoms is moderate. Again, I would like to emphasize it's people who have a modic type 1 change in their disc herniation. I will not be surprised if this pans out in the future, given the propensity for bacteremia, which always happens in human beings, and said bacteremia going to areas of recent trauma. So often patients present with bacteria in some organ or other that they recently injured or strained. I think the data is interesting. It really all points the same way, and that a subset of patients with back pain probably have infection in their disc space. And me, When you look at the treatment study, I would be inclined to go with IV therapy rather than oral, and I probably would get a biopsy before I embarked upon a course of therapy. But then I'm an ID doc. I tend not to do empiric. You know Newton's law for clinical trials. For every study, there's an equal and opposite study. We do chlorhexidine baths in our ICUs because there are studies to show it decreases infections. Now, of course, there's a study out that does not show a decrease in infections in ICU patients. They had 9,300 patients in the study in 5 ICUs, and patients either got 2% chlorhexidine for 10 weeks, which was followed by a period where they did not. And there was no difference in the primary outcome, which was a composite of central line bloodstream infections, catheter-associated UTIs, ventilator-associated pneumonias, and C. difficile. Of course, the problem was it was a composite endpoint, and I would wonder if C. diff would be affected by chlorhexidine baths. With the exception of a dose of perioperative antibiotics at the time of incision, I have come to the conclusion that probably antibiotics are a surrogate solution for otherwise inadequate infection control policies and procedures. I am sure with this article we are a month or two away from a meta-analysis and systematic review of chlorhexidine baths in the ICU. I think the preponderance of data suggests efficacy, but the preponderance of data also suggests that infection control adherence is suboptimal in many places, parenthesis, not in my hospitals, in parenthesis. So we'll see. There'll probably be another study that shows benefit. Newton's law goes back and forth. And I would still use chlorhexidine perioperatively for patients who are having prosthetic devices put in. As long as we're talking about Staph aureus, this study looked at the incidence of staph found in the oral pharynx and found it was not uncommon to find MRSA in the mouth. 18% of specimens had Staph aureus. That doesn't really surprise me. I tend to think of human beings like Pigpen and Charlie Brown, and I figure staph is actually everywhere. Any place you put your finger, you're going to find staph. And it looks like they're putting their fingers in fire stations, as they found in this study 58% of fire stations in Washington state had MRSA in them. And to this I think, who cares? Any place humans put their hands is going to find a pathogen. That's why we wash our hands before and after visiting patients in the fire station. And it sounds like firefighters need to be a wee bit more fastidious in their infection control, since they are blaming patients as the source for the MRSA. So, what's the best treatment for invasive aspergillus? This study compared voriconazole plus inidilafungin versus voriconazole versus placebo, and found that at 6 weeks, combination therapy had a mortality rate of 19%, monotherapy had a mortality rate of 27.5%, with a miserable 0.87 p-value. And I still think a p-value of 0.005 is probably your minimal cutoff, so I'd say that ain't statistically significant. Whether a larger number of patients would have shown better benefit is uncertain. They do note that is an issue with their study. The mortality rates were lower than expected, and they only had 454 patients total in the group. So maybe if they kept going, that p-value would have stretched out. But what do you do when you don't get a difference in your primary endpoint? Well, you do a post hoc analysis. Remember Zygris? They did a post hoc analysis. They showed that if you had a high Apache score, perhaps you had better outcomes with Zygris. But it was approved on the basis that they repeat the study. In the meantime, $1 billion was spent on Zygris. The study was done looking at high Apache scores, and guess what? As is always the case, or not always, but often the case, the post hoc analysis is garbage. They had a post hoc analysis that suggested that there were subgroups that benefited from combination therapy. Those with radiographic findings and a maximum galactomannan positivity. Even then, the p-value for the difference was a pathetic 0.37. So the best you can say is maybe. but I'm unimpressed with the data. But I predict that now people are going to use nanijalifungin and voriconazole for invasive aspergillus. There is other data to suggest that combination therapy might be superior, so I don't poo-poo it entirely. But let's just say combination is more of a Hail Mary based on wishful thinking than it is grounded in good clinical trials that prove efficacy. But that's always the case in the treatment of complicated and rare infections. We'll just finish off here with a hodgepodge. As always, if you want details, that's why we have the internets. As you probably know, though, there is an ongoing problem with enterovirus D6 that's causing acute flaccid myelitis. We have a couple cases here in Portland, evidently, in kids. But that seems to be a problem. Hepatitis E prevalence in the United States has been decreasing in the era between 1988 and 1994 compared to 2009-10. The rates of hepatitis E seropositivity have fallen for reasons that they do not know why. If you're screening for chlamydia, add rectal screening and you will increase your yield for finding the chlamydia. If you vaccinate mom against pertussis, baby is protected, which is pretty important given that you cannot vaccinate newborns, and it's the newborns who tend to die of pertussis. So making sure mom and the family members around the baby are vaccinated against pertussis is very important. Tick-borne relapsing fever is in the Bitterroot Valley of Montana, United States. For all my international listeners who are going to vacation in Montana, since they now don't want to go to Disneyland and get measles, although we have all of Europe to get measles from if you really want it, I suggest you go to the Bitterroot Valley in Montana and get yourself a case of Borrelia hermsii. There's a series of cases out of France of Clostridium sordelii causing foot infections. They had 15 cases. It's interesting that sordelii normally causes a post-abortion syndrome with hemoconcentration and rapid death. These strains all lacked the toxin gene, which was nice. And like other sordelii infections, it was also associated with intestinal neoplasms, i.e. bowel cancer. A cool case of a patient who developed African histoplasmosis 40 years after leaving an endemic area. Unlike love, histoplasmosis evidently is forever. If you have tuberculosis and you will go on to get influenza, at least in South Africa, you're more likely to die. So it's a bad combination to get two infections in your lungs. In California, cigarette smoking is a risk for developing pulmonary tuberculosis. That's been true in multiple studies. And if you're interested in traveling to areas of high risk for infectious diseases, might I suggest Marin County, Northern California, where there is a distinct lack of vaccination. Doctors' electronic devices, i.e. tablets, often carry germs. A big deal. Wash your hands. Nobody cares. And finally, an interesting article where they tested the prevention of malaria transmission by giving people not only anti-malaria drugs, but ivermectin. And ivermectin kills mosquitoes. And as such, they decreased the spread of malaria by taking care of the vector by giving people ivermectin. That is a clever idea. And an awful case, a child who died of Naegleria. They got it from a hot springs in Costa Rica. Another waterborne illness. Sad. And that brings us to the end of this Puscast, covering the last 2 weeks of January 2015. If you're fascinated by the topics, you can go to the references on the internet and dig up the original article and go into gruesome detail. Those references can be found at edgydoc.com, along with the rest of my growing, yes, it's in Chernobyl, my growing multimedia empire. Don't forget to wander on over to Amazon and buy the Pus Whisperer, the perfect gift for the pus lover in your life. And finally, don't forget I'll be speaking at Nexus along with my other science-based medicine cronies on April 10th, a full day of science-based medicine. And I'll be giving a whole bunch of talks at the SMAC conference in Chicago coming up in June of 2015. Go to smacc.net.au to find out all about the SMAC conference. Otherwise, as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation. Goodbye. If you heard some occasional shouts in the background, my son is watching the Blazers play Milwaukee. Evidently, it's exciting, so I'm going to go down and watch the rest of it. Talk to you later. Bye.